Today's session is focused on incorporating technology to advance more coordinated and equitable behavioral health care. And we are excited to have a number of individuals joining us today that have contributed to the development of the AMA Manat Behavioral Health Integration Return on Health Report that was published earlier this year. Alec, if we can go to the agenda slide. During our 90 minutes together this morning, we will start off with an overview of the BHI Return on Health Report. And then we have two individuals, Dr. Matthew Press and Dr. Edward Post from Penn Medicine and Veteran Affairs, respectively, who will highlight BHI models at their organization, how digital health tools have been incorporated, and the comprehensive value recognized. After these three presentations, we'll then come together for an interactive panel discussion with speakers where we invite you as the audience to ask questions live. And with that, I'd like to introduce our first speakers today, Chris Botts and Jared Ogenstein. Chris Botts is the Care Delivery and Payment Manager within the Professional Satisfaction and Practice Sustainability Group at the American Medical Association. In this capacity, he helps advance AMA's practice sustainability efforts by removing obstacles to patient care and enabling physicians to learn, adapt, thrive, and lead in a rapidly evolving healthcare environment. This includes leading the AMA's Behavioral Health Integration Initiative, focused on catalyzing effective and sustainable integration of behavioral and mental health care into physician practices. Jared Ogenstein provides strategic planning, business strategy, project management, and policy analysis and design services to healthcare providers, startups, states, and other healthcare organizations. Jared's primary areas of focus are advising clients on digital health, telehealth, digital delivery system transformation, population health, federal and state health policy trends, and provider markets. Jared serves on the advisory board of the Center for Telehealth and eHealth Law and on the Leadership Council of Executives for Health Innovation. And with that, Chris and Jared, I'll turn the floor over to you.
Fantastic. Well, thank you so much, Bernadette, and thank you all for joining us today. Really excited to talk to you a little bit more about the report that we released earlier this year, and really excited to hear more from Dr. Press and Dr. Post about some of their specific efforts. So, the AMA and Manat brought together a group of multi-stakeholder perspectives ranging from large health systems and independent practices, large employers, health plans, and patient advocates to really come together to really focus on three primary areas, one of which was to identify opportunities and challenges with incorporating technology for integrating behavioral health care. The second was around really identifying practical solutions for how these stakeholder groups, as well as venture-backed or publicly traded behavioral health companies, can really move the needle forward in adopting and advancing behavioral health integration. And then lastly, really doing a deeper dive into how the AMA's Return on Health framework can be used to really measure the true value that integrative care can bring to the table for our healthcare ecosystem. And this slide here just provides a list of all the various different stakeholders that we had involved. I think the really important part here is just the wide variety of folks that were able to bring to the table, and the fact that they all agreed to have their participation publicly available. They had the option to really opt out, and I think everybody really found that this was a really important topic, and that there was agreement across these various stakeholder groups on the importance of moving the needle forward within the specific space. And as we were talking about this work, we really identified four main areas that frame the importance of why we brought this group together. The first one was the agreement across these stakeholder groups that expanding the adoption of behavioral health integration was really an essential part of solving our nation's growing healthcare crisis. Behavioral healthcare crisis was really just has been exacerbated these past few years by the COVID-19 pandemic. The second of which that there are a number of digital tools that can be adopted to accelerating integrative care. And those have just proliferated even more with the pandemic. And so there's a lot more opportunities than even a few years ago in terms of how to leverage digital technologies to really move the needle forward within the specific space. Also understanding that all stakeholder groups, so not a singular one by themselves, can really have an impact on making this a reality for patients and for the healthcare system writ large. So there's really an opportunity across these stakeholder groups to all have specific solutions that they can put forward to have impact in this specific space. And then lastly, as I mentioned, agreement that the AMA's Return to Health framework really can be a valuable tool in terms of measuring the value of integrative care. And we're going to talk a little bit more about of that in a few minutes. So as the group began talking, there were several opportunities that they had identified across the patient journey, the integrative patient journey, where technology can be leveraged. And that's ranging from intake to remote patient monitoring, telehealth, all the way to some digital therapeutics. And it's important to note as part of this graphic that while there's a lot of opportunities that group identified, really the majority of work to date primarily focused within the telehealth band here in the middle of the page. And a little bit in the digital intake. And again, we'll hear a little bit more from Doctors Press and Post about how they're leveraging some of these opportunities within their specific systems. But I also wanted to note that many of the folks in the work group noted that they're at least exploring many of these other areas. So I think there's some opportunities for growth moving forward, and we're interested to see how that plays out in the years to come. But as the group really began talking, they wanted to first emphasize the opportunities that digitally enabled behavioral health integration can have, primarily around enhancing patient management and treatment. There's a lot of opportunities for these types of technologies to really do what everybody is focused on for integrative care, which is really helping support patients and their needs. These technologies can also play an operational role in terms of both supporting integrative care in terms of some of the other types of services beyond just direct patient treatment and management, and really can help limit the fragmentation across the various different providers and the integrative clinical team that's involved with this type of care. And then lastly, it really can help provide additional value for, most importantly, the patients, but as well as the providers, as well as some of the other stakeholders that are involved in this type of care. But even with these opportunities, it was really important that the group emphasize the fact that technology can't replace the need for in-person care. And more importantly, it really should be focused on enabling or improving the longitudinal relationship between the provider and their patients. It's really not meant as a replacement, but more of an enhancement. The other important part is the fact that for many of the items that was identified in the prior slide, there's still a lack of robust clinical or economic research that really shows the impact that this technology can have, which was really stagnating both the uptick, I think, of some of these technologies, as well as alignment for some specific regulatory or coverage decisions that are happening either at the federal, state, or commercial payer level. And additionally, I really wanted to emphasize the fact that technology is not always clinically appropriate for all patients or even available for all patients, and understanding that there's a preference differentiation between both on the providers and the care team, as well as patients, as well as understanding that there may be issues or gaps when it comes to digital literacy or just in terms of access from a broadband standpoint. That really comes into play when it comes to trying to implement these types of digitally enabled integrative solutions. And as I noted, one of the areas that the group talked about was leveraging the AMA's Return on Health framework, specifically focused on how it could be used to measure the value of integrative behavioral health care. And the group really identified and recognized that all the areas within this framework were really critical in terms of being able to move the needle forward and really recognizing the complete value that integrative care can bring, not just for, as we talked about, access and patient outcomes, but also understanding what it means for the clinical team, as well as being able to really enable some of these cross-cutting issues like health equity and the like. And as part of that conversation, the group started identifying some of the specific measures that could be utilized within these specific areas. And I'm not going to go through these with a fine-tooth comb, but I think the important part to keep in mind when it comes to these specific measures is, one, there still is an alignment from these different stakeholder groups in terms of what their priorities are within these specific areas. Large employers have specific perspectives in terms of what they want for their employee populations. And while there's alignment with some of the other stakeholders, that's not the exact same as a provider group, for example, that's looking to measure the value of what integrative care is bringing to them. The other part that's important to keep in mind is that many of these measures can be quite cumbersome still in terms of being able to actually capture this information, nor is this information necessarily available for all the stakeholder groups that are, or readily available to many of the stakeholder groups that are involved with this process, which can, again, make it challenging when it comes to true coordinated integrative care. Really want to make sure that the measurement aspect is both aligned and accessible in a timely fashion for all those who are involved, which is a really critical part to making integrative care successful. So, folks, if you have some interest, can do a deeper dive into the report and really look at some of these measures. But the group agreed that more conversation needed to be had in terms of doing a deeper dive into some of these measures and really creating alignment, particularly when it came to some of these federal, state, and commercial products, to really make sure that integrative care is as easy as possible to facilitate ultimately impacting the patients that these types of models are really trying to serve. And so with that, I will pass the virtual baton over to you, Jared, who can cover a little bit more specifics about some of the opportunities that we identified as part of this work.
Great. Thanks, Chris. And it's great to be with everyone today. And this is a great discussion. Really excited about our Dr. Press and Dr. Post, who are going to speak a little bit later. So Chris did a great job kind of summarizing a lot of the setup of the convening and the report that was issued. And I'm going to focus my comments mostly on some of the recommendations that the group made to different key stakeholder groups. And I'm going to focus on 5 key stakeholder groups in particular: physician practices and health systems, health plans and coverage programs like Medicare and Medicaid, federal and state policymakers, employers as providers of health insurance coverage, and private or publicly traded behavioral health companies, telebehavioral health companies in particular. So first, I'll focus on physician practices and health systems. So the 4 opportunities identified here were, first, to increase behavioral health diagnosis and treatment rates by incorporating evidence-based digital health solutions and enabling technology into standard workflows. There are a lot of tools available, but they're not universally adopted, or even the level of uptake is very low at the moment. Address the siloed delivery of care by primary care specialists and behavioral health providers by implementing technologies that facilitate care coordination and enable highly collaborative care. Third is to raise the provision of evidence-based treatment to best practice standards level by adopting and integrating standard measurement tools into provider and patient-facing technologies, such as patient portals, and by promoting data-driven continuous quality improvement. And finally, by integrating BHI training for primary care specialists and behavioral health providers by incorporating digitally enabled BHI into standard curricula at the medical school level, the residency and fellowship level for physicians, and during training for other types of clinicians as well. The second stakeholder group is health plans and coverage programs. The first recommendation here is to increase BHI adoption by expanding coverage of and fair payment with a margin for all stakeholders utilizing the collaborative care model and other BHI models that facilitate care management and transitions of care for patients with behavioral health conditions. The CPT codes for the collaborative care model have been in place for several years, but uptake is not universal from a coverage perspective, and payment can vary significantly across health plans and coverage programs. Second is to encourage the incorporation of telehealth into BHI by implementing payment parity for behavioral health services delivered via video or audio-only telehealth modalities. And that basically means that telehealth services delivered via video or audio should be paid at the same rate as that equivalent service would be paid for if it were delivered in person. Third is to make integrated behavioral healthcare more affordable for people by evaluating how and when to apply cost sharing, such as copays, including eliminating cost sharing when appropriate for collaborative care model codes, as well as integrated behavioral health services, whether they're delivered in person or delivered via telehealth. Fourth is to assist primary care practices in integrating behavioral health by offering technical support, provider training, and regional sharing of resources. And there was one representative from a payer who had a very successful program providing technical support to primary care practices that's outlined in more detail in the report. And finally, expanding provider networks and improving access to behavioral health integration by minimizing or eliminating prior authorization and other utilization management practices for behavioral health integration services. Next, I'm going to talk about federal and state policymakers. There's a bit here, so bear with me. So both for federal and state policymakers, helping primary care specialists overcome financial barriers to adopting BHI by providing long-term sustainable funding opportunities and fair payment rates with a margin for providers delivering BHI services in federal and state coverage programs like Medicare and Medicaid. Again, for federal and state policymakers, providing funding to achieve universal and affordable access to broadband internet. Telehealth is only as good as your ability to access it, and as we know, there are significant parts of the country that don't have access to broadband internet. Some 30 million people still don't have access to or can't afford broadband internet. For federal policymakers, pass legislation to remove originating site and geographic restrictions for all services in Medicare that limit access to care. Now, there's actually been some progress on this since the report was published. There is going to be some additional flexibility around originating site and geographic restrictions for telebehavioral health services, but it's limited in scope, and there are some other challenges with that rules around periodic requirements around in-person care that are going to create a kind of different set of challenges. Again, for federal policymakers, growing the behavioral health workforce by increasing federal funding for efforts such as loan forgiveness and new residency and training programs, and advancing the evidence base for BHI by funding health services research related to digitally enabled BHI with a focus on health equity. For states, there are opportunities to increase adoption of telehealth within BHI by requiring private payers and Medicaid programs to cover behavioral health care delivered via video or audio only at parity with in-person care. That's the same kind of parity requirement that we were discussing for health plans. And for states, expanding access to behavioral health integration and reducing coverage-related barriers by prioritizing adoption of BHI within primary care initiatives and working with health plans and coverage programs to strengthen networks and ongoing consumer awareness. For employers, the group identified opportunities to enhance coordination among employers, employees, primary care specialists, and behavioral health providers by adopting technologies that enable coordination among providers and by contracting with primary care specialists that offer BHI in addition to further analysis and standard setting for private, particularly venture-backed or publicly traded behavioral health companies that enable or are complementary to primary care specialists to adopt BHI to drive delivery of highly coordinated, high-quality behavioral health services throughout their entire primary care system. And second, to reduce out-of-pocket costs for employees who are seeking care by evaluating how and when to apply cost sharing, again, including the option to eliminate it where appropriate for integrated behavioral health services conducted in person or via telehealth. And finally, opportunities for private or publicly traded behavioral health companies include evolving the current and developing new business models to support BHI that address patient and physician needs, complement in-person care, support comprehensive care delivery, and enable synchronous and asynchronous communication among providers and patients. And second, to generate robust clinical and economic evidence for digitally enabled BHI by working with stakeholders to develop national standards for BHI technologies and by partnering with practices to test new solutions and develop clinical and economic evidence. So now I'm going to hand it back to Chris, who's going to introduce our next speaker, Dr. Press.
Fantastic. Thanks so much, Jared. Looking forward to potentially doing a deeper dive into any of those solution areas during the Q&A session. So next, we're really excited to be able to have Dr. Press with us. He's the physician executive of Penn Primary Care. and the medical director of the primary care service line at Penn Medicine. In these roles, he helps lead clinical operations, practice transformation, and population health management across a network of 90 primary care practices in the University of Pennsylvania Health System. From 2018 to 2020, he served as the interim chair of the Department of Family Medicine and Community Health in the Perelman School of Medicine. Prior to his positions at Penn Medicine, Dr. Press was a member of the senior leadership team at the Center for Medicare and Medicaid Innovation at CMS, where he helped develop and implement several new payment and care delivery models, including ACOs, bundled payments, integrative mental health, and medical homes. His work has been published in the New England Journal of Medicine, JAMA, Health Affairs, and has been covered by the New York Times and the Associated Press. He received his medical degree from Brown University and completed his internal medicine residency and the RWJF Clinical Scholars Program at the University of Pennsylvania. So thank you so much, Dr. Press, for joining us today, and I will turn things over to you.
Thanks, Chris. It's great to be here, and I really appreciate all of the work that AMA is doing related to behavioral health integration. From my point of view, this is the #1 issue that we need to tackle as an American healthcare system because of its great prevalence of mental health problems, the impact that mental health conditions have on both quality and cost of care in the U.S. and the lack of access to high quality, affordable mental health care across the country. When I was at CMS now, probably about 7 years ago, we were looking for ways that we could help support integrated mental health. And I got to know while I was there very well the collaborative care model. And the collaborative care model, for those who don't know, is a evidence-based model of integrating mental health into primary care that's been around for a few decades. There are over 80 randomized controlled trials that show its impact, particularly on mental health outcomes, but also data showing an impact on improving medical comorbidity outcomes as well as lowering total cost of care. So I was involved with the creation of billing codes for the collaborative care model when I was at CMS. And then when I came to Penn Medicine with the charge of leading primary care transformation and population health management, I felt that we would never be successful in the world of population health management and value-based payment without a really effective integrated mental health program. The toll that mental health conditions were taking on our patients and their outcomes, as well as the impact on our primary care physicians, is tremendous. And so our first priority in our efforts to transform primary care and take a population health approach to care here at Penn Medicine was to launch an integrated mental health program that is based almost entirely on the collaborative care model. And I would refer those who aren't that familiar with the collaborative care model to the AIMS Center, AIMS, at the University of Washington. They've been the pioneers of this model, and on their website at the AIMS Center have several resources to help providers, health systems, payers, and others rally their support around collaborative care. And I think it's having an impact as we start to see collaborative care popping up across the country. The only tweak that we did on the collaborative care model, which is a team-based approach. So in my primary care practice, I have a behavioral health care manager. That's kind of the key new role that works very closely with me. And then that person and I are supported behind the scenes by a consulting psychiatrist. So you take the really scarce resource of a psychiatrist and you spread it over a much broader population by leveraging the primary care physician and the behavioral health care manager that's working with the primary care physician. And patients prefer to get their care in primary care because of the low stigma and easy access. So for many patients with mild to moderate depression, anxiety, some substance use, they can effectively be treated and all of their mental health needs met in the primary care setting through this evidence-based model. The only wrinkle on the traditional collaborative care model that we implemented was to create a centralized, what we call a resource center, but it's essentially our intake assessment and care coordination center. The reason we did this, I'm just going to go back here. The reason we did this is because we felt that when we launched, there would be such a tremendous demand on this program that if the initial intake and assessment happened in the practices, that would occupy all of the time of the behavioral health care managers. And we really wanted to preserve that time to focus on delivering the treatment intervention, which is about a 4 or 5 month intervention of meeting with the patient, consulting with the psychiatrist, working with the primary care physician. So we centralize that intake process. But otherwise, our model looks just like the collaborative care model that you'll see described in the AIM Center. In terms of the finances of our program, we leverage the collaborative care billing codes that were mentioned earlier. Those are, time-based codes. There are some challenges with the codes, but we wouldn't have a program without them. That's how we fund our program. We did need to make some initial upfront investments, but that's really the key revenue source for our program, and has allowed us to have a sustainable business model to continue to grow. So we launched in 8 of our practices in the city of Philadelphia in 2018. At this point, we're at about 20 practices. We added 12 or so outside of the city of Philadelphia. We have across our primary care network over 100 practices, and our goal over the next year or 2 is to get collaborative care into all of those practices. So just, to go over what the workflow looks like or what a patient experiences. So, typically a patient will see me in the office, and we screen everyone with a 2-question depression screen, the PHQ-2. If that's identified as positive, we'll have the patient complete a PHQ-9. That may be one way we identify a mental health issue. A patient may come in to see me for a concern around a mental health issue, or I may identify it over the course of the visit. In any of those, through any of those channels, the next step is for me to place a referral into the resource center that I mentioned earlier. Currently, that intake process happens over the phone. But one of the things we're most excited about from a digital perspective is a tool that we've been developing for some time now. Actually started during the pandemic as a tool to help support our employees. We're now have been working for a while on trying to modify that to really support the collaborative care model in our primary care practices. So we did do a pilot in one practice, brief pilot, where we used that tool rather than have the patient have a phone intake, have them use a web-based intake that we created, and we're continuing to work on that, and hopefully that'll enable us to scale our program more rapidly and broadly. Once the patient completes that intake, there's a determination made based on their answer to the questions, and the questions are a series of standardized mental health symptom assessments. Patients can be triaged either to collaborative care in their primary care practice if they are low, moderate acuity. But if they're high acuity, what our resource center does is help identify the right specialty mental health provider for that patient based on their need, helps facilitate their appointment. We'll follow up with them after the appointment to ensure they met it and see if they need any other support. But for that low, moderate group, it's about 50-50 split, depends a little bit on the practice. For that low, moderate group, they then get scheduled with the behavioral health care manager that's in my practice for their initial visit. And then again, over those next 3 to 5 months, they'll meet about every other week with that care manager. They'll have evidence-based interventions like mini cognitive behavioral therapy or behavioral activation, motivational interviewing, really problem-focused brief therapy, essentially. The care manager is in meeting weekly with the consulting psychiatrist to review the active panel of patients. So again, it's not just a one-to-one model that you see in some co-located models of integrated mental health, where you may have a therapist come for a day or 2 a week. They tend to fill up quickly. They tend to have some no-shows that can be a challenge. With this model, it's really a disease management approach. So the care manager will carry a load of about 80 patients at a time, 70 or 80, depending on the acuity. Once the pandemic hit, we converted almost all of that interaction between the care manager and the patient to digital tools. So we use phone, and or video for that interaction. And again, looking to this new digital tool that we're developing to help our care managers manage their patient load as those patients come in and out. One of the keys of collaborative care is assessing patient symptoms. So, mental health, this is an issue in mental health everywhere, that we don't use measurement-based care enough. And unlike diabetes or hypertension, I would never treat somebody's diabetes without measuring their blood sugar. I would never treat their high blood pressure without measuring their blood pressure. But for too long, we've done that in mental health. So a hallmark of collaborative care is regular assessments of their symptoms using one of the standardized assessment tools. And so our digital tool will help our care managers track that. Currently, they do that within our electronic health record, which is adequate, but we can make that process even more efficient. This aligns with the framework that Chris presented earlier. Again, we've launched the program about 4 years ago now. Our outcome metrics are improvement in the PHQ-9, which is a depression assessment, and GAD scores, which is an anxiety assessment, are in the 40 to 45% range. That means 40 to 45% of patients who complete an episode of collaborative care have remission of their symptoms, which is on par with all those randomized controlled trials that have been done for collaborative care. That's pretty exciting for us, being a real world implementation, that we were able to see the same outcomes that we're seeing in a more controlled setting. And that improvement in outcomes has persisted despite the transition to more digital or telemedicine interaction between our care manager and our patients. We built into our EHR a really simple referral process, and we said to our primary care providers, refer whoever you want to this program. You don't have to worry about will they be appropriate for collaborative care or not. We'll make that determination. And I think that's been really key to make that a digitally smooth process for our providers, and they really love this program. It's transformed the way that they're able to deliver care. We talked a little bit about the billing codes and a little bit about the startup costs, which can be significant. But again, we're fortunate in our area to have payer support of the billing codes, and that's really helped us continue to grow our program. In terms of health equity, we absolutely see a difference in terms of referral rates for specialty mental health care in our practices in lower income parts of the greater Philadelphia area. And so we've had to increase the number of care managers in those practices to help meet the needs. We also see a very high proportion of patients having experienced trauma. Trauma currently is not part of the collaborative care model, although we're looking into adding some trauma-informed care into our program. But those patients need to be referred out to a specialty mental health provider, and that still is a challenge, access to specialty mental health providers. But what collaborative care does is it's essentially like a denominator solution. If we can keep half of patients' mental health care in the primary care setting, we're reducing the number of patients that we're trying to push through that narrow funnel of getting to specialty mental health care. So then really only the patients who most need specialty mental health care are going through that funnel, and ideally that should open up access. With that, I think I'll hand it over to Dr. Post.
Fantastic. Thanks, Dr. Press. Looking forward to potentially some additional questions. I know I've seen a few already come over, can provide even some more context for your all's fantastic program. Next up, we have Dr. Post, who presently serves as the Senior Advisor, the Director of Primary Care Operations for the Veterans Health Administration Office of Primary Care. And he also serves as the co-chair of the Ambulatory Council for the VA Electronic Health Record Modernization. From 2007 to 2020, he served as the National Primary Care Director a VA primary care mental health integration. As a practicing primary care internist and mental health services researcher, he also is the professor of internal medicine at the University of Michigan Medical School and an investigator at the Ann Arbor VA Health Services Research and Development Center for Clinical Management Research. Dr. Post received his medical degree from the Medical College of Virginia in 1991, completed his residency in internal medicine at the University of Michigan in 1994, and received his doctorate in 1998 from the University of California, Los Angeles as a primary care research fellowship. Dr. Post, hand it over to you.
Great, thanks so much. Very happy to be here and appreciate the opportunity to present. Dr. Press did a really great job, I think, of summarizing at a high level the collaborative care model. As he said, over 80 randomized controlled trials showing that there's a great empiric foundation for this. A lot of that has been, and he alluded to this a little bit with the dearth of evidence for the collaborative model in trauma-informed care and PTSD, which is highly prevalent in the VA. But the sense that the collaborative care model really has an evidence base that's largely based on depression. Now, to the extent that that's a primary care evidence base, those patients, as we know as primary care clinicians, are going to be highly comorbid. It's very hard to tease out and have pure depression from anxiety. So, and there is absolutely a substantial body of literature as well, not as voluminous as the depression literature in collaborative care model, but definitely for patients who do have more of a pure or trending anxiety disorder without depressive components, definitely a substantial literature showing that that has approach as well. However, the platform itself conceptually is pretty agnostic diagnosis. I think a lot of it gets to the positioning, to where the resources are. Especially care is still going to be a place for a lot of practical reasons why there's going to be highly specialized resources where people need to do very intense and perhaps some lengthy treatments. But nonetheless, it's just important to have that frame when you're thinking about that. One of the key issues, I think, is really trying to stay faithful to the biggest touchstones in the empiric literature, at the same time adapting that locally. And that is always a slippery slope, at which point you are simply translating away from the effective components. And Harold Pincus, for example, has talked about this with, exactly what's the key issue here. How do we avoid having voltage drop in actually implementation practice? But I think he did an excellent job of summarizing that. In the VA, we've taken an approach that has really had more of a hybrid of the collaborative model, along with some co-located resources as well. But a lot of the touchstones that Dr. Press mentioned will be familiar with our journey as well. We do ultimately start out with a population-based approach where we screen veterans, often on an annual basis for behavioral health conditions. We often have warm handoffs. Even if we're having a care manager, it's always great for them to put a face to a name. Even before the pandemic, although the use of video and telephone and distance technologies to deliver care has markedly increased during the pandemic, the care management component has often been telephonic or video. Nonetheless, warm handoffs can be key, and they're absolutely central to our more co-located component, which is really focusing on crises as well as when there's a need for a diagnostic evaluation. And those warm handoffs are to designated team members. We do have mental health integration staff within our greater, it's called PACT, the primary care medical home model, patient activated care team for those veterans who do have lower acuity behavioral health needs. We do have digital support options which have been in place, not only for patient provider interaction pre-COVID, but also for population health and other aspects of a full integrated model. But now the majority of our care management behavioral health visits within our program have been conducted virtually. So to dive down a little bit about the VA model, nearly 95% of our veterans on a regular basis are screened for a variety of core mental health conditions. Those include depression, PTSD, alcohol use disorder, as well as most recently, the last few years, specific attention as a screening in and of itself to the concept of suicidality. The PTSD component is screened after patients have had are 5 years out from their last separation from the service, once every 5 years. The remainder of these are done annually. Often in primary care settings, although that's not the sole venue for treatment, some patients parenthetically also only come to the VA to get their mental health services. But across a wide variety of settings with a heavy focus on primary care as a site of performance, we do screens. And those screens in primary care are usually conducted by a medical assistant or a licensed practical nurse. We do have RNs within our primary PACT team, separate from any RNs on our integrated team, who also serve as like a general care manager within the core primary care team. We made a decision early on that the expertise and the need for supervision for the collaborative care model would really have us focus on nurses or social workers or even clinical pharmacists as care managers within the integrated mental health team. And so we really chose not to interleave mental health disease-based care management with the duties of the core primary care registered nurse. So that leaves the eventuality that if there is a RN care manager on the integrated mental health team, that you might have someone interacting with two RNs for those care and case management activities within the primary care staff. And part of why we have the RN involved in that and not at the front line of screening and check-in is that that's really a higher level function. So we oftentimes want to have that higher level function not be used with checking people into clinic and doing the screenings themselves. So there really are layers of the team, some of whom interact more in real time, the MA and the LPN with, say, the primary care physician pretty routinely at every encounters, and other team members are available depending on what the patient's needs are. When a positive screen is identified, the primary care physicians can, in some cases, use counseling dialogues. For example, we effect a standard script for brief interventions for alcohol use as a function of our clinical reminder system within our present electronic health record, and they can conduct that brief intervention. And then depending on what the additional needs are, and even for other conditions beyond alcohol, then the primary care clinician has the prerogative during the provider visit to either take sole care and follow up depending on the condition, or to involve our mental health integration team, who in many circumstances are proximate within the primary care venue, or depending on what their judgment is, potentially with complex patients, are able to refer them directly to specialty mental health care. So there's really there's a continuum of mental health, of which the least intensive aspect of our mental health system is essentially forward deployed into primary care, in a manner of speaking. Again, depending on those acuity and needs, the primary care physician can have that warm handoff. That warm handoff would involve the integrated mental health team, which generally speaking is going to be dealing with, just like Dr. Press mentioned in their system, lower acuity behavioral health needs, depression, anxiety. We do often have some initial evaluation. PTSD as a diagnosis becomes somewhat fraught. It is often a diagnosis that is screened and contemplated. It's often not necessarily given its definitive diagnosis within primary care settings. That has a lot of implications for whether people are service connected or not. And I think generally that serves the balance of not having mixed messages, which can be confusing or perhaps even disappointing to some degree to veterans, as well as making sure that they get the best possible evaluation consistent with what their preferences are. That can be an issue in a sense that oftentimes we have highly specialized team who would be very willing to see patients for trauma-based care, and especially mental health, but oftentimes our patients don't necessarily want to go there. So one of the tensions we have as a health system that has a lot of mental health resources is what would be the best place on paper for the veteran and where would they want to go. And so sometimes our mental health integration program is basically at the point where we're trying to define, in concert with the primary care clinician, what the patient is willing to accept as far as a modality or a setting of treatment, and trying to provide them something. That sometimes creates some extrapolation from the evidence base, but that is not really any different than real life with primary care, where maybe the referral pathways are not happening, that essentially you become the de facto treatment venue, even though you would like to do elsewhere. We have that with just a couple more degrees of freedom as well. And that actually works out reasonably well. Sometimes that less intense treatment that may not be the gold standard for the evidence base becomes a run-in, so that patients are willing to engage in more. And you see that a lot with PTSD, because avoidance is a hallmark of PTSD. And so that is all to the good by and large. But it certainly, is something you reflect in reality that you wouldn't necessarily think about purely on paper. We do have a wide variety of disciplines. We have psychologists, licensed clinical social workers who have specific mental health training. We also have general social workers within primary care who often serve case management and deal with a lot of home care issues and other types of complex psychosocial needs that are slightly separate from their mental health needs. We also have, as I said, registered nurses who are deployed in these different aspects. We have also a continuum of providers who can prescribe medications, nurse practitioners, physician assistants, as well as psychiatrists. We also have some peer and mental health technicians. As Dr. Press alluded to, prescribers are in particularly short supply, and that is absolutely the issue here. We do have a tension sometimes with our limited number of prescribers as to how we can have a role so that they can have the best supervisory role for our collaborative model participants, our care managers, who, as I mentioned, are generally RNs or social workers or pharmacists. We do also have a small number of licensed professional mental health clinicians as well, who can potentially serve in that role. That becomes a tension because having that supervisory aspect is difficult. We've tried to allow kind of a hybrid model where psychologists in times can be a part of the supervision aspect, and that's just really kind of based on our workforce reality. That obviously creates some challenges with respect to medication consultation, but you can even manage that with a short aspect of prescribers who are available away from specialty mental health by having them focus on the collaborative role where you have a difficult medication choice to be made and you need a consultation around that, versus bread and butter psychopharmacology, which can often be handled by our primary care clinicians themselves because the medication choices are more straightforward. And then, as we both mentioned, that patients who either immediately or through treatment failure or an inadequacy of having them get to remission and to meet their goals may have a need for a higher level of care, and that's where patients can go to specialty mental health care. In terms of our digital components, we do have an integrated electronic medical record across all of our areas with only the inability to see really privileged psychotherapy notes. All of our mental health records and our primary care records are available throughout the EMR. We are in the process, it was alluded to, of going to a commercial system. We will be running one instance actually with the Department of Defense. So right now we are running, we're running before we started that launch, 130 instances of CPRS, as it's known, our EMR, the same program at different instances at 140 of our facilities. There are a few that are shared. But when we go live with this, and it's going to take the better part of a decade, we will all be on the same instance, and we will have a lot of task efficiency in that regard, and we'll have a lot of integration of data that isn't fully reconciled on the back ends of multiple instances. We do have some digital clinical decision support. That's an area that I think is going to greatly expand, and it's going to be absolutely central, as all of the disciplines we're talking about are really facing workforce pipeline challenges going into the future. So I think I think some of our traditional ways of working in our silos and worrying about our reimbursement, that's where some of our value-based payment models and our capitation models, as well as just reality, are going to have us really going away from the traditional paradigm and realizing that we need to work together. And I think that's in some ways going to create a stress. It may have financial implications, but it's going to be a tremendous stress towards working more collaboratively, and that's going to be excellent. We do have an extensive system of instruments, patient-reported outcomes, largely done by staff entry. We are working on front ends so that we can have more convenient patient-based entry. We do have video as well as phone visits. We do have our back-end data, which we do leverage extensively through syndication. All of those 130 threads actually come together and can be used with respect to dashboards and reports. That is often what I think about as being interfaced. The syndicated data we're able to have a separate reporting platform that will show us insights across all those instances and is really more interfaced in a way. Whereas, as we mentioned here, we're really looking towards having registries and tools that are more integral to new EMRs as well. We presently do have some registries and some population health tools that are interfaced with our current system. And I think one of the challenges we have with informatics is in really taking those things that can be highly interfaced towards making them truly integral so that you can have one sign-on, you can have full awareness across a team of what's happening, as opposed to having different applets, which to some degree can recreate silos across the different aspects of the interprofessional team. And as I mentioned, we're trying to work on creating patient-facing entry of patient-reported outcomes as well. And then we've actually been working, I would say that planned is probably that warm handoffs by a video. I think we're getting increasingly better at being able to do that because we often have the reality where our teams are really doing very modality hybrid type of things. We have nurses calling on the telephone and sometimes calling ahead of time to support video visits. And then we have providers who may be working from home for various reasons, including COVID, and are able to do that distance technology and interact with veterans on video. We have them maybe in the hospital doing video to the patient's home. We have people still in the traditional face-to-face, so there's a whole variety here. And so I think there's a lot of learning and a lot of logistics that are happening as we deal with this reality. And I think what we've seen is the push towards the modality mix has actually helped us greatly through the pandemic. You know, obviously in terms of our type of practice, looking at the value paradigm that we were asked to populate here, we're obviously a national health system serving veterans in the VA. We are largely a budget-based model. We do have some external third-party reimbursement that is largely based on whether people are service connected or not. But in a large respect, we have an internal capitation model, which essentially represents prepaid healthcare for a good majority of our circumstances, but not entirely exclusively. In terms of social determinants of health, we have a mix of younger veterans, especially with our current conflicts in the last decade, going back to 9/11 essentially, as well as older adult veterans who have from diverse geographic regions. All of these patients have different circumstances. Some people have private insurance, and they have certain aspects of service-connected disorders that they bring in. They have very discrete needs. Some veterans we may see once a year. We may see them twice a year. They sometimes have that because if they have long-term care needs, they're going to need to rely on the VA more. They may use us as their Part D plan in a manner of speaking. Other people bring most of their care to the VA, regardless of whatever age. And some of our younger veterans who have been, in a lot of ways, have challenged us the most because they are highly mobile, they like technology, and they've really pushed us to interact with them in a way that serves them. I think that's been a really good impetus. So we have a variety of needs, and we work really hard to listen and to make sure that we're asking the question, what can we do to serve you? We need to provide them the best technical advice. We don't want them to go down a track that's not going to be clinically successful for them. But again, we also need to elicit what their preferences are and guide them, because a plan on paper that never comes to fruition is just an academic exercise. And so that's really where the dialogue is very helpful. And as I mentioned, we have a variety of virtual care modalities. Our screening protocols, looking at the 5 major pillars here, represent our ability to really define what our needs are and represent a large amount of intake. As Dr. Press mentioned, measurement-based care, I think, is key. You know, that is something that we are still working to leverage, especially out the back end, to be able to use those measures to longitudinally follow veterans, to more quantitatively evaluate our episodes of care, as well as to use that as a way to see if patients have fallen off of care when they've been previously treated. So measurement-based care immediately gets you into a lot of the technologies and a lot of the back-end issues, and that can become very complicated. But I think there's a huge promise here, especially with respect to patient-facing aspects of that, either handing a patient a portable device in which they can do that as check-in in the clinic, or having them do it asynchronously, for example, doing a PHQ-9 that's been issued to them at some interval in a patient-driven portal. So I think there are huge opportunities there. Access to care is absolutely key in the VA, and a lot of our visits are conducted virtually now. On a population level, we actually look at the proportion of our enrolled primary care veterans who have a primary care physician, and what proportion of that population at each of our facilities is served by our mental health integration program. So we look at when we call that kind of like a penetration rate. So if a practice or a subunit or even a facility had a 10% penetration rate, that would be, for example, that in the course of a year, they had 1,000 veterans who got at least one integrated care service among an enrolled population of 10,000. And that number has been about 8% nationally. Like any large system, there's going to be inter-facility variation, but that basically means that we're serving about 1 out of 12 of our veterans in primary care with some mental health service. If they go straight to specialty mental health, that's not going to be included, but we do have a significant overlap of people who either need to pass through after failing an integrated approach, or they potentially, and this is the less efficient aspect of it, they potentially pass through mental health integration as kind of an initial step. We try not to encourage that, especially because if that was self-evident at a time, then the initial evaluation is potentially not adding value. Dr. Press mentioned that they've really formalized an intake process. We've left that a little looser, and what that does create is the fact that needs to come to a local accommodation that does get to the actors in terms of who accepts responsibility and is not necessarily formulaic. And so to some degree, that has been one of both the promise and the peril in terms of how extensive a given facility staffs their integrated care and exactly how they conceptualize this so that each actor who is touching someone is clinically astute, is hopefully tracking the patient efficiently so that we have the ability to get them into any treatment they need as quickly as possible. So we don't have a nationally standardized intake in that sense. Some patients I mentioned avoid seeking out mental health care. So that is a point at which mental health integration, especially to the extent it could put a face on the extremely reluctant, is very helpful. If I have a patient who absolutely, I do not want to talk to mental health, and that's not an uncommon scenario, I can often get them to say, well, I understand that, I'm not going to disrespect that, but would you please meet Brian or Mary as part of my team? And just having them come in and say, I'm part of the team. Here's a card. You can get back to me through Dr. Post or whatever. That's often very helpful because oftentimes, especially mental health, is not only less accessible, it's a point at which you have to set up a different appointment in space and time, but it often becomes the point at which a patient or a veteran is not sure what they're getting into. They're reluctant to commit. There can be some logistical barriers, but even when they get there, it becomes very extensive, and it can. They may not. They may have their worst fears that are there, and so by basically understanding that Mary and Brian look exactly like me, that can go a little way towards really getting them really interested over time. Ultimately, patient autonomy in the absence of a crisis or really compelling circumstances is really important. But at the same time, as primary care physicians, we also need to realize that we're not going to win the war in any day. And so oftentimes we just need to chip away at this, and we need to, just like with respect to diabetes care and diet, we need to work on these constantly. We need to be getting the patients back towards a rational point of care and not making the perfect the enemy of the good. That is, in essence, the primary care, challenge. Providers see value in being able, as I said, to connect our veterans, and our modalities, as we say here, are really important. Medication reconciliation can be a real challenge in any setting. One of the things, especially if a patient doesn't come with the person who's assisting them at home, they may not be able to answer a question in the office. Whereas if I call them on the telephone or do a video visit and we get to that same point, I can say, guess what? I'm going to take a few minutes. You're going to go to your medicine cabinet. We're going to reconcile this as well. So we've actually seen some real silver linings to some of the things we've seen in addition to patient convenience. The other thing we can do is not just bringing patients back to the office for our own convenience. We've learned that in the pandemic. If I could give the patient back an hour of drive time and parking, I can tell them, well, why don't you go out and take a walk and start working on your exercise plan? So I think there's value to be had from having a nimble mix of modalities. And so I think we've learned all those things coming out of the pandemic. As I mentioned, there is, of course, interfacility variability, and that is absolutely something that we work on constantly. In terms of health equity, I think the VA, with a diverse service members that ultimately become veterans, that we're able to meet their needs greatly. And there's been a lot of literature showing that we actually have very equitable outcomes across those categories. With respect to mental health integration per se, the one empiric study I think we've had is that we've looked at the aspect of gender, and we've seen highly comparable depression care by gender. In summary, I think really the key points here are that the technology really needs to assist your procedural vision in a practice. The technology itself should not define what your procedural vision is for what you want to do with a program. So you got to make sure you get that right and not put the cart before the horse. Value generation is absolutely going to be key. Having a dialogue with the veterans and seeing what modalities you can offer them and what they have acceptable is going to absolutely be key. And then looking far in the future, I think having really clinician and perhaps even to some degree patient-based. We're seeing this with computer-aided psychotherapy, but I think having a provider-based clinical decision support that's going to drive us to be able to be more efficient is really what we're going to be able to do with the data. And so I'm very excited about clinical decision support looking well forward from here. With that, I want to turn it over and happy to participate in the Q&A.
Our next event will be held on August 3rd and will feature Mayo Clinic leaders who will showcase their efforts to advance digital health across their organization. And in sharing their experiences, they will highlight key issues that impact the ability to efficiently and effectively operationalize digital health tools and the opportunities that still remain. If you have any additional questions for our speakers, we invite you to join our Physician Innovation Network. It's our virtual platform where we connect physicians and entrepreneurs and other industry stakeholders to have conversations around digital health and technology. So if you are not already on that, we invite you to join. And then lastly here, I just want to thank so much our presenters for today, Dr. Press, Dr. Post, Chris, Jared, thank you so much. And thank you all so much for joining. We will talk to you soon. Thank you so much.